بسم الله الرحمن الرحيم. شكرا دكتور سيد على التقديم بداية نتقدم بخالص الشكر والتقدير لحضراتكم على تشريفنا في الدورة ال 18 للمؤتمر جمعية سعيد مصر للسكري، أو زي ما الدكتور سيد قال في طريقها إلى أن تكون جمعية مصر للسكري. ويعني بنسعد بكم ونأمل إن شاء الله أن يكون المؤتمر يعني موفق وأنه يحقق الاستفادة اللي مطلوبة منه. احنا مش عاملين يعني افتتاحيات كبيرة ولا حاجة، لكن بس بنرحب بحضراتكم. I think we don't have any non-speaking person here, have we? Okay. 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 Sorry for that. I'm just trying to welcome you all to the, and Ashraf as well. Well, I'm just want to welcome you all to our 18th conference of Upper Egypt Diabetes Association, which is now on its way to become Diabetes Egypt rather than Upper Egypt Diabetes Association. This is the new name of the association, and this is our international conference. And we have here, it is done in collaboration with Diabetes in Asia Study Group. And we have, I can see members of Diabetes in Asia Study Group. The president of Diabetes in Asia Study Group, Dr. Misbah, is present here. Maybe they'll arrive tomorrow, Misbah? Tomorrow they'll arrive? Diabetes in Asia Study Group. Well, the delegate of Diabetes in Asia Study Group, we have delegates from Pakistan, Bangladesh, and India. They will arrive tomorrow, inshallah. And now we will have people from outside Egypt, but not now. I'm very happy really to have you with us, and I shall start immediately because we are a few minutes late than our schedule, and I shall start immediately with an important. I believe it's a very important topic actually, which is the management of obesity from the viewpoint of diabetes, because we have news regarding the management of diabetes or regarding the management of weight in diabetic cases. So well, this is obesity. Obesity is a chronic and even progressive, most of the time, condition with many medical, physical, psychological complications, but its effect on diabetes is quite substantial. And the relationship between diabetes and obesity is quite evident. And well, it's very, because a reduction of weight is beneficial both in prevention and in treatment of diabetes and its complications. We know for sure that mild weight reduction is effective in prevention of diabetes. And it can improve glycemia, of course, for diabetic patients. And larger amount of weight loss is effective in getting remission to those people with diabetes, especially those overweight patients. Significant weight loss, like what happened in metabolic surgery, the bariatric surgery, improved quality of life, improved cardiovascular complications, and reduced mortality. It's increased age. Obesity, so That's the conclusion from this introduction. Obesity is very strongly related to the development of diabetes and its complications, and getting rid of obesity is very important and very efficient in prevention of diabetes and its complication as well. We have very strong evidence regarding that, because pre-diabetes treatment, we know all, of course, the diabetes prevention program published almost 20 years ago in the diabetes care showed that very straightforward reduction of 5 to 10% of the weight will reduce the incidence of type 2 diabetes by slightly less than 2/3. We can protect 2/3 of diabetic patients just by reduction of their weight, or 7% or something. So prevention or delay of diabetes, and this prevention and delay of diabetes can persist for 10 years. They followed up those people, and they found that the reduction of weight is still effective after 10 years in prevention of diabetes. Diabetes remission is a more recent information, of course, for those who are obese and recently diagnosed, less than 7 years. Reduction, larger amount of reduction, 10 to 20% of the body weight can result in remission. Remission meaning that the patient can stay below the level of diabetes regarding glycemia without taking any drug. This is the definition of remission. And in those patients, in addition to the pathogenesis here, that it's not only improvement of insulin resistance, but improvement of insulin secretion as well. And this is in the form of C-peptide, of course, will normalize in those patients the C-peptide production. So the mechanism of diabetes remission, that they found that the reduction of weight inside the liver will improve insulin resistance, and reduction of fat inside the pancreas will improve and normalize insulin production. That had changed the pathogenesis, the classically said pathogenesis of diabetes. This is a classic teaching of pathogenesis. I won't go through that because I don't have enough time for that. But the assumed mechanism is that impaired glucose tolerance will result in reduction of secretion of the ability of beta cells to produce insulin. And if this hyperglycemia became constant, if it remains for enough time, the failure of beta cell will be constant and persistent, and it won't be back. But in the early stage, if we can reverse that hyperglycemia, then the beta cells can resume its function again and can continue. This is the new part of the pathogenesis of diabetes, which we recently, actually we discovered that just 3 years ago, that it is a reversible process. Non-obese individuals, non-obese diabetic patients were observed to have increased fat content of the liver and pancreas in spite of the fact that they are not obese. So the question raised, what will happen to those patients if we reduce their weight, just to get rid of the fat inside the liver and the pancreas? And this is a study funded by the Diabetes UK to answer that question. And the result is very interesting. The result was less than 1 year ago. It's the 1st of April, 2022. Those patients who were not obese at the start of the trial, they lost in the average about 8% of their weight. It's not 20% like those others. And in spite of that, 70% of those patients went into diabetes remission. So, and the hemoglobin A1C decreased from 7% to 6.3%. So those patients improved without treatment in spite of being not obese at the start. These are very good news, actually, regarding the management of diabetes. Well, this is the obesity, the standards of care of diabetes, which is produced by the American Diabetes Association every year, now is making a special section in these standards of care regarding obesity management. And these are the three methods of management of obesity: nutrition, physical exercise, and behavioral changes. That should include everybody, starting from body mass index 25 until no matter high the body mass index is. But if failed with patients between 25 and 27, then we can add, by the time add to the lifestyle modification, we can add pharmacological therapy. After 30, we can think if lifestyle modification and pharmacological therapy were not enough to control the condition, then we can start thinking about surgery. Now, the metabolic surgery, there's a friend, Farid, I think, will speak about metabolic surgery and lifestyle modification. I won't speak about that, but I would like just to have a small presentation about pharmacological therapy, because we have new drugs now, and I would like just to shed some light on this pharmacological. These are the three methods of treating obesity. Now let's have a look to the pharmacological therapy. It is one of the most needed and most frequently failing things which happened during the last few decades, and until the year 2014, we did not have any approved drug to treat diabetes, and the history is full of failures regarding that. Can remember the fen in the 90s, with a single small study had led to millions of prescriptions of this combination of drugs, which led to serious heart diseases and a huge number of mortality, and the drug was withdrawn in the year 1995. Rimonabant, that's another drug which was encouraged and applauded regarding its ability to reduce obesity. But after a short time, when they started their trial, they observed that there had been a significant excess in depression, neuropsychiatric side effects, and suicidal tendency, and the drug had never been approved. Now we have three drugs which can substantially reduce weight and without any serious side effects, and these are the drugs. Liraglutide, once daily injection. This is a GLP-1 agonist, of course you all know, was approved in June 14. This is the approval in treatment of obesity, not diabetes. And semaglutide, and I'm mentioning the generic name here, the trade name, because it is not present here in Egypt. Unfortunately, the other two drugs are not present in Egypt right now. And I'm saying just in a moment why it is an unfortunate thing. It's a one-weekly GLP-1 agonist, semaglutide, agonist injections, and approved in June 2021 in management of obesity. A couple of years before, it was approved to treat diabetes. And the third is the tirzepatide. The trade name is Mounjaro. It's a one-weekly, it's a dual agonist for GLP-1 and GIP receptors, both drugs. And this is, again, I don't have time to speak about the detailed mechanism of action. And that was approved less than 1 year. It's May 2022 approved for treatment of diabetes, but not yet. It has not yet been approved to treat diabetes. Maybe very. This is a fast track. They call it the fast track approval by the FDA, and this is one of them. In placebo-controlled trials, of course, the liraglutide is not mentioned here. Number one, because it is not very recent. Number two, because the effect is very minor when it is compared to the other two drugs. So placebo-controlled trials proved that tirzepatide, I used to mispronounce it, tirzepatide or Manjaro, a dose of 10 to 15 milligram per week achieved more than 20% weight reduction, 20% more reduction, and it arrived to 25% in many cases. While semaglutide, 2.4 milligram achieved about 17%, which is a huge reduction. This is 7 to 10-fold compared to placebo. Placebo can reduce weight, of course, but this is the difference in these levels, percent of body weight reduction resemble what is typically achieved by bariatric surgery. They are almost identical to bariatric surgery, which is something very, these are what's called the breakthrough. This is a real breakthrough, actually, but wait a minute until I complete my presentation, not be very happy. These are the weight reduction which is achieved by 5, 10, 15, and the other by semaglutide less than the previous one, of course. This is how they work. Of course, they enhance satiety, delaying gastric emptying, increasing insulin and insulin sensitivity, decreasing glucagon, and of course, reducing high blood glucose. These are the GLP-1, we all know about it, effects, but it is augmented by increasing the dose. This overlap, the two are overlapping regarding the mechanism of action, and it is overlapping as well with the side effects. Nausea, vomiting, abdominal pain, constipation, and diarrhea, all the side effects very well known to happen with GLP-1 agonists. In spite of that, only 4 to 6% stopped the drugs because of these side effects, compared with 1 to 2%. So the difference is not that huge, and they are overall safe regarding the side effects. Both drugs achieved favorable effects on lipid, reducing triglycerides, LDL, and raising HDL, along with reduction in blood pressure. And this is a direct effect of weight reduction, of course. In spite of having a concern regarding acute pancreatitis, it didn't happen. It is not proved through the randomized trials that acute pancreatitis is a real concern. And there is these are the rare effects, but one of them is the potential medullary thyroid cancer, and this is very well known again with the GLP-1 agonists since they start, but it is quite rare. What does that mean? إيه معنى الكلام ده? We have 1 billion obese people right now in the world. 650 million adults, and the rest are adolescents. So we have a huge number of obese people in the world right now. And that epidemic is relentless, لا تتوقف, and progressive, تتزايد طول الوقت. And the main problem of that is that it's taking diabetes with it. This is the main cause of the increasing incidence of diabetes, the progressive increase in the incidence of diabetes, which results in increasing cardiovascular complications and mortality as well. So, have we solved the problem now by introduction of this drug? These are the downsides. Number one, the cost, of course, and the cost is terrible, actually. Semaglutide is very expensive. Well, أنا عندي 2 slides إن شاء الله هخلصهم بس بكلمتين. Semaglutide very expensive, $1,500 per month. ده الكوست بتاعه في أمريكا. هنا لسه ما، على فكرة موجود في الخليج، لكن هنا لسه ما وصلش. في الخليج سعره أرخص. المونجارو بيكلف 1000. للديابيتس لسه ما تسعرش للدوز الثانية اللي هي بتعمل الأوبيسيتي. طبعا they are injectable. دي واحدة من الاعتراضات، هل هيتعمل اورال فورم؟ عندنا اورال فورم لسيماجلوتايد تو تريت دايابيتس، لكن ما عندناش بيحاولوا انهم يعملوا اورال للاوبيسيتي. الناس هيبطلوه. لما يبطلوه هيحصل ايه؟ لو ما استمروش على اللايف ستايل موست بروبلي الاوبيسيتي هترجع مره ثانيه. دي مشكله. الكوست طبعا، الكوست ده مشكلته انه اتس اكسسربيتس ذا انيكويتي، الظلم اللي هيمارس على الناس اللي محتاجينه مش هيقدروا يجيبوه. في الوقت ده الممثلات كلهم في امريكا الان بياخدوا وهم ما عندهمش اوبيزيتي، وبياخدوا سيماجلوتايد لانه حفاظ على البودي ايمج فعندنا في ظلم بيقع بشكل ضخم على الناس. بالاضافه للفياجرا والبوتوكس، اصبح الويجوبي اصبح هو سائد في وسط اللغه العاميه للناس، اصبحوا بيتناولوه بنفس الطريقه. في كونسيرنز طبعا عن preventing access للدراج للناس اللي هم كواليفايد. في مالتيبل ايجنتس نازلين، هل هيرخصوا السعر؟ مش منتظر انهم حتى لو نزلوا الجينيركس، يعني مش منتظر انهم يعملوا كده. الكوست افكتيف ستاديز بتتعمل حاليا، لكن هيطلعوا قد ايه ممكن يبقى حتى اقتصاديا مفيد لو اتعمل كده. حتى لو جت عندنا جينيركس مش منتظر انها تخفض السعر بالشكل المطلوب. في عندنا طبعا ادويه زي الدواء اللي بيعالج الهيموفيليا اللي بيكلف $3.5 مليون للواحد، لكن ده حالات رير كيسز ان كومباريزون مع فيري هيوج ابيديميك زي الاوبيسيتي. يبدو ان احنا بالرغم من ان حققنا انتصار ضخم، لكن يبدو انه هيصطدم بمساله الكوست والافكتيفنس. So, in conclusion, these drugs may represent one of the most important medical breakthroughs in history, which may signify the end or the marked reduction in the need of bariatric surgery. Thank you.